The following podcast is part of a certified educational activity titled Redrawing Frontlines in MCL, the upfront expansion of BTKi options and modern clinical decision-making in newly diagnosed disease. Access the entire activity and complete the post-test at peerview.com/GKD860. Downloadable slides and practice aids are also available.
Here we are. Welcome everyone here in this annual meeting, ASH 25. So if you're interested in pets and whatever kitchen furniture, this is the wrong location. But what I am quite sure, we have an excellent faculty, and what we try to convince you that really first-line treatment of mantle cell lymphoma have changed. So it's no more chemotherapy alone, but it's really a combination with targeted therapy, namely BTKi is cornerstone, already first-line treatment of mantle cell lymphoma. So on behalf of the faculty, Cami Maddox from Ohio State and Christine Ryan from Dana-Farber, I'm privileged to welcome you. My name is Martin Dreiling. I'm located at University of Munich. So let's move back for today's agenda. What we try to communicate is really that guidelines of mantle cell lymphoma have changed significantly during the last year or so. And now essentially all international guidelines do include BTKi as part of first-line routine standard in mantle cell lymphoma. We will discuss the underlying evidence. What are the study data suggesting that? And this is really implementing all these three different parts: standard chemotherapy, BTKi, but also challenging autologous stem cell transplant. And then we will move on to older patients. And I would like to remind you that the median age of mantle cell lymphoma in our studies, maybe you may say 60 to 65, but in real life it's more in the range of 70, 75. So this is really the second part, focusing on the vast majority of our clinical routine patients. And finally, we will together have a look into the future and really targeting on chemo-free regimens, which potentially may become one future standard of care, maybe for older, maybe for frail patients, but maybe also for all kind of also younger and molecular high-risk features. Then I would also like to introduce you to the HealthTree Cure Hub. What is that? This is all about networking, and that is really a direct-to-patient approach, connections to more than 3,000 hospitals, including single patient records, and this is really a treasure. And so this is, implemented also by Pro and demographic data. And here you are. This facilitates clinical routine and real-life data surveys and studies. So this is really a treasure to work on. And there's also a lot of education going on concerning articles, concerning updates, for example, of this year's ASH conference, but additional information, also patient guides, and you see that here, expert webinars. So please have a look and go through that. So this is the registration status, so the background of what we are talking about, and what you can see is that BTKi are registered in first-line mantle cell lymphoma worldwide. And just as an example, here we have the European Union and the United States, and there's a slight interesting difference in that way that in ibrutinib is approved in the European Union, ibrutinib as first generation, and the second generation BTKi acalabrutinib. On the other hand, in the United States, for formal reasons, ibrutinib had been withdrawn, but acalabrutinib and zanubrutinib, both second-generation BTKi, are registered. Pirtobrutinib is a little bit confusing, also called BTKi, but it does have a different mechanism. So it's also valid in relapsed mantle cell lymphoma after prior BTKi, approved in both regions. And finally, there are also ongoing phase 2 studies with third and fourth generation BTKi. Let's have a look at the guidelines. Here we are on, this is on your left side. This is the preferred induction therapy, and this is NCCN. And then I would like to refer. This has been ordered according to the alphabet, so not in a ranking order. And for example, triangle has been mentioned there with category 2A for ibrutinib, category 2B for second line BTKi, but we will have a look at the data, whether this is really valid. And then for older patients, preferred regimens is being listed acalabrutinib plus BR. And you see there are also some suggestions about chemo-free options in the guidelines. What about the European guidelines? And here I took the recently published EHA guideline. What you can see again, it's a little bit more graphical because we would like to guide our colleagues, what are the standards, and you see if that is available in your system. Combination of BTKi plus chemotherapy is really standard of care in both the young fit patients and the older patients. All right, so this starting point, to give you a little bit insight, as I said, we split up the subjects accordingly, so I have the easy job to start with the young fit patients. And here's an example. This is Robert. He's a 65-year-old chap. He has a typical stage 4 mantle cell lymphoma with bone marrow infiltration. ECOG performance status is reasonable, which is usual in mantle cell lymphoma. MIPI is intermediate, but I already told you that should not necessarily guide your treatment. On the other hand, on your right side, these are the important things. LDH is mildly elevated. Q67, this is a real life case. So it's just at, the cutoff of 30%. It does have non-blasted morphology and P53 wild type. This is to be mentioned. All this is mandatory to be performed by your pathology before first line. And he's fit. So let's have a look at the data. What should we do? The underlying study is the triangle data, and this is exactly where we did compare chemo alone versus the combination plus ibrutinib. And this is on your left side, and you can see a clear-cut superiority. That was somewhat expected, but what is quite interesting, that even if you skip autologous and instead apply ibrutinib, you see a significant benefit of modified PFS. And that, in fact, now so if both of these ibrutinib-containing arms are improving outcome, the question is, plus minus autologous transplant, do we really have to keep it? Because I tell you no secret, when I'm telling you, you may like autologous transplant, but your patients don't like it. And therefore, there should be really a strong rationale for that one. And this is where we split according to these biological risk factors. And what you can see is Ki67, here we took the MD Anderson cutoff of 50%. Lower than 50%, there is no benefit whatsoever for the autologous transplant. In fact, there is a disadvantage. If you see the early course of the course, there is a disadvantage of adding autologous transplant. Why is that? This is the procedure-related early toxicity we all know. On the other hand, on your right side, these are the patients with high Ki67, and I could put in P53, I could put in blastoid. They all look similar. You see that there is a benefit, improvement of progression-free survival with a hazard ratio of 0.62, and that's quite significant. Well, it's not significant. It's clinically relevant, but it's not significant, and it probably will never become significant because the numbers of patients are just too small. So what is our conclusion? Well, in the high-risk patients, you may individually consider to add autologous transplant. Why not just add it for everyone? Well, the reason is you buy in toxicity, and that is illustrated on this graph, and that's specifically for pancytopenia, and this is not during the procedure of autologous transplant, but during the 2 years of follow-up. essentially saying if you have really the triple combination, autologous transplant, and then the double maintenance rituximab plus ibrutinib, you see you come up with significant hematological toxicity, more than 50% grade 3, 4 toxicity, and that translates also in an increase of infections. So this is what you have to keep in mind when you advise your patients whether to apply autologous or not. This is probably the strongest message of this trial. Now with a long follow-up, 5-year follow-up, you can see there's a huge benefit of overall survival in the range of 10%, again, in favor of both experimental arms. And therefore, luckily, this is one of the few examples where our health insurance already, agreed early on, about 2 years ago, that they will reimburse the application of ibrutinib. Okay, let's go back to our chat. As said, age and presentation did not change of this patient. And now here we are, and probably we'll start with questions to our esteemed faculty. What is your conclusion out of these data? Can BTKi combinations be considered on the current evidence and guidelines? How do you evaluate the triangle, specifically considering that ibrutinib is not registered in US for mantle cell?
So the way that I approach these patients is I do think that we can take the triangle data and in a young fit patient apply the idea that we can use BTKi-based combination therapy to give them induction and then eliminate the autologous stem cell transplant. This data used the BTK inhibitor ibrutinib. We do not have that available here, but our guidelines and I think our experience has been such that you can use a second-generation BTK inhibitor and get similar outcomes. I think the data, we've never seen head-to-head comparison in mantle cell, but we know that the efficacy across these BTK look very similar, and it's really the toxicity that drives differences. So if anything, maybe you'll get a little bit better toxicity profile by substituting one of the other BTK inhibitors. So in my practice, I have adopted this, and I have I really have eliminated transplant in this patient population.
So, Christine, what about you at Dana-Farber? What is your standard approach in such a patient?
Yes, I completely agree with Cami. So, this is a patient who would have fit exactly into the triangle patient population. And from the data we just reviewed, very clear that adding a BTK inhibitor, of course, in triangle, ibrutinib to upfront induction and maintenance does improve overall outcomes. So I think very clearly, and I know we'll review the ECOG-ACRIN study as well, but I think together those data sets really have solidified that there is a much smaller, if not no, role for transplant in the frontline setting.
Mm-hmm. The question is really, we have these data on this huge study with almost 900 patients for ibrutinib. But we also know, there are a couple of BTKis, and they are at least partially registered in mantle cell lymphoma. And on your left side, it's first generation ibrutinib. On your right side, it's second generation acalabrutinib and zanubrutinib. And what you see illustrated here is that the second generation BTKi do have a higher specificity. Sorry. This is a non-native speaker in jet lag. And so therefore the question is really, you could suggest that this is also translating into lower toxicity. And Kemi, you already commented, we do have these data in CLL and other entities. I would like to add, this is probably not that much concerning hematological toxicity or immune suppression, but it definitely is for cardiac toxicity, namely atrial fibrillation and also bleeding. Now, in the triangle trial, I have to be honest, there was only one cardiac death, and this death was in the control arm. Why is that? We picked the super fit patients. We picked the patients not only qualifying for a study, but also qualifying for autologous transplant. So these are probably not the patients you have in real life. And if you do the same in older patients, you will see more challenges. Anyway, been presented at last year at ASH. We also have data exactly for this combination, now not with ibrutinib, acalabrutinib, by our Australian colleagues, and these are early days, but what you can say concerning overall response, this looks quite encouraging, and the 2 years PFS is about 73%, overall survival close to 80%. So that brings me to the point what you already addressed a little bit. Should we move on from ibrutinib, expecting that the data for Triangle hold up also for second generation? Well, you already mentioned that you're considering that. So I ask you now, I start with you, Christine. Is it possible in US to get ibrutinib in this indication?
I have to say I have not tried, Martin. I think with the as you showed initially in the NCCN guidelines, with the second generation BTK inhibitors being listed there, generally that is what we are reaching for now. I have used ibrutinib in other settings, so it is still available, but I have not used it for mantle cell lymphoma since it was withdrawn.
And what is your favorite second generation BTKi? That's a question for both of you. And then I will be honest, I will also tell you my preference.
I think there definitely is a lot that could be debated about the two, and reasons to choose one or the other. I will say right now we actually have a clinical trial with zanubrutinib in the Frontline, so that I would say is what I've been reaching for, and perhaps a little bit more. But we also have a clinical trial with acalabrutinib for high-risk patients, so I really used both and seen excellent outcomes with both.
Yeah. So to the first point, I'll just say I've not tried it either. I know there are some people that feel like this is the data. And so there are people that have used in the US that have used ibrutinib in that situation. As Christine said, it is still available. I think, though, it's challenging because of the number of caplets, the dosing that it's available in, and it's not the easiest access for patients. I wouldn't say I have a favorite. I use them both. I would say that because we participated in a lot of the earlier trials with acalabrutinib and I was very used to using it, that I tended towards that as my default for a long time. But then with Bovin data, I started to use more zanubrutinib. And so I do use both of them in practice.
Fair taken. So I mean, we have to be honest, there are no comparative data between acalabrutinib and zanubrutinib in a larger patient population. If you do a study-to-study comparison, exactly, especially in CLL, my personal readout is that acalabrutinib is a little bit better tolerated when it comes to also hematotoxicity. However, everyone is afraid of the initial headache of acalabrutinib. Just a reminder that this is occurring in about 10% of patients. My personal experience is if you educate your patient accordingly, saying, well, this is easy going, you take, a painkiller for a couple of days, and then after 2 weeks, this thing is over, that they rather easily tolerate it. Initially, I was a little bit afraid, and patients are afraid when you tell them, oh, we have this little pill and now you will get serious headache, but it's in real life, it's not that serious. Okay, let's move on. What do you think, if you, for this presentation at least, you take some kind of chemotherapy for granted, what will be the next steps to build on these treatment combination? What would be if we're close to Christmas, so you don't have 3 wishes, but each of you have 1 wish free. So what is your wish, how to evolve treatment in mantle cell lymphoma, including chemotherapy in the combinations?
My wish is to not include chemotherapy in any combination in any patient.
Fair take. What about you, Christine?
Yeah, I agree. I think, both us and our patients, there are a lot of toxicities of chemotherapy. I think, though, Martin, as you highlighted with the elevated Ki-67 patients, there may be a subgroup of patients where we still don't know the optimal treatment approach, and there may be a role of chemotherapy. So I guess I agree, but I might tweak it a little and say identifying those patients for whom we really, and only those patients for whom we need to have chemotherapy.
You're saying a very important point. In that way, the young patients are the least challenging normally because they, on average, have a lower risk profile, and therefore, we have brilliant data. So we really increased overall survival. We were coming from 20% after 10 years, 30 years ago, and now we are about 85 to 90% after 5-6 years. So there is really a transformation of the kind of disease of mantle cell lymphoma. But Kemi, sorry, you wanted to mention.
This we're talking about how BTKi has revolutionized the frontline treatment for mantle cell. And I think probably the next generation of discussion is how going to be how like our immuno and cellular therapy, so our bispecific antibodies and CAR T cell that have changed second line and third and later line, hopefully.
Here's Robert. He's still 65, but he went through the induction, the triangle, like with a BTKi, and now we are at end of induction. And he is PET negative, he has a PET CR, and he has also achieved a molecular remission. No significant toxicities during therapy, so you could move on to autologous transplant. And you can see that he nicely responded. LDH is normalized, and nodal bulk has significantly decreased. And he says, well, okay, 6 cycles are fine, but now I'm a little bit tired of treatment. So how do you advise this chap? Well, luckily, to the ECOG-ACRIN trial, we now have solid data on this scenario. And this shown here, a huge study with more than 600 patients where after induction, systematically, PET and molecular remission has been detected. And for the patient becoming MRD negative, it has been randomized plus minus autologous transplant. All of them did receive rituximab maintenance for 3 years, but arm A, autologous transplant was intermingled, whereas in arm B, SCT was skipped. And after a reasonable follow-up of 2.7 years, you see there is no difference whatsoever on overall survival, and that is both randomized or treatment as assigned. And you might say, well, overall survival is maybe a little bit early, but it's exactly the same for PFS, and there's no indication whatsoever of a major difference between this. So essentially saying, well, for the patients achieving a molecular remission after induction, you definitely don't need the consolidation. But maybe I overinterpret the data, and I wonder of our esteemed colleagues. Christine, do you agree, or are there any scenarios where you still would go for autologous?
I think that between the ECOG-ACRIN study and the triangle data, as I mentioned, for me, patients in this scenario, I'm not taking them to transplant anymore. I think the data, gold standard, randomized, plus minus transplant, as you saw, those curves were entirely overlapping. So for those patients who are MRD negative, really, I do not think there's a role for transplant.
Now for Kemi, I will make the question a little bit more difficult, telling you that all the data on MRD we have were on chemotherapy only. In fact, the early data for the triangle regimen did not clearly indicate a prognostic role of MRD. Would you still skip autologous transplant in this patient?
So my approach to this is if you can access BTKi in the front line, that I am not going to use autologous stem cell transplant regardless of the MRD based on the triangle data. And I would say that I have been able to access, particularly now with the frontline approval for one of the drugs, that a BTK in the front line. If you were only giving chemoimmunotherapy and we're not going to use, the BTKi with that or as a maintenance approach, and the patient was still MRD positive, then that would be the small subset of patients that I would say there would still be a role based on the data for autologous stem cell transplant consolidation.
And I have to apologize to you. That was a nasty question because what I didn't say with a longer follow-up, also for the iBroad imatinib combinations, you see the impact of MRD. But this is an important point to consider. Patients being MRD negative, in contrast to DLBCL, they are not cured. They still may relapse. And in fact, these are the patients who benefit most of maintenance strategies. And therefore, you should not then cut all kind of treatment, but you still go on for maintenance. So take-home message, important and that has been already addressed by Christine and Kemi, we have to consider the molecular risk factors if we want to fine-tune the treatment of our patients. I showed you a couple of data that adding BTKi significantly improves overall survival by 10%. And in high-risk patients, it still may be an individual discussion of autologous transplant or not. Being in the real life, about 80% are classical risk mantle cell lymphoma in first line. So we're only left with 20%. And then in these 20%, there are always a couple of reasons why you shouldn't go for autologous transplant because of toxicity during induction and so on. So I think essentially for 95% of patients or so, we are very clear that we should skip autologous transplant, but there are still these exceptional cases. And what you have also seen, MRD assessment does allow for fine-tuning during the course of therapy. And with that, I think I was a little bit over time, so we just move on to you, Kemi, and then we may come back for questions at the very end in the roundtable discussion. Go ahead. Now you are going for the real challenges.
Okay, so thank you, Martin. So now to kind of switch to the opposite patient population, which, as Martin mentioned, is most commonly the population of patients we see in practice. And that's the patients who are older, have comorbidities, and are not considered candidates for consolidation autologous stem cell transplant. So our patient is of Megan. So Megan's a 73-year-old female, also with stage 4 mantle cell lymphoma, which is most commonly seen, ECOG performance status of 1, MIPI indeterminate, which Martin told you is less relevant. But other findings, LDH is elevated, Ki67 is high at that 35% mark, so greater than 30%. But otherwise has non-blastoid morphology and wild-type TP53. Underlying conditions include hypertension and chronic kidney disease. So let's look at the data here. So the first large attempt to incorporate BTKi-based therapy into the treatment in this patient population came from the SHINE trial. And this was a randomized phase 3 study that randomized over 500 patients who were 65 or older and considered not candidates for more intensive treatment, including consolidation with autologous stem cell transplant. And patients were randomized to either standard chemoimmunotherapy in this setting with BR times 6 followed by rituximab maintenance versus that plus the addition of ibrutinib. And in this trial, ibrutinib was given through chemoimmunotherapy and then after with rituximab maintenance and then continued until progression or toxicity. This was a positive trial in terms of the primary endpoint was progression-free survival, and there was a statistically significant improvement in PFS. In fact, the PFS with the addition of ibrutinib increased from about 53 months to 80 months. However, when we looked at overall survival, the overall survival in the trial, there was no difference in overall survival. And after a little over 7 years, the overall survival in both arms were pretty much exactly the same. Now, the concern really came with this regimen when we looked at the toxicity issues with the patients who were on ibrutinib. So if you look, there was a similar rate of all-grade toxicity in both arms and not that big of a difference of grade 3 to 4 events in either arm, a little bit more in the BTK. But when we really drilled down on the toxicities, there was a higher rate, over 15% more patients that discontinued therapy with BTKi versus placebo due to toxicity. A lot of that concerns came from infectious toxicity. And really what we saw is while there were more deaths related to progressive disease in the standard arm, there was a higher number of deaths related to treatment emergent adverse events with the BTK inhibitor. And based on the concerns that were raised with the toxicity of this is where it was ultimately decided not to pursue the full approval for this, and ibrutinib was withdrawn from the U.S. market, as Martin had mentioned. That trial really failed to move the needle in getting us an approval in the frontline setting for BTKi in this patient population. However, we then had the phase 3 ECHO trial, and this looked at the same patient population, but tested the addition of acalabrutinib, second-generation BTK inhibitor. The design was very similar in terms of patient population, therapy, and primary endpoint. The difference, in this was it used a second generation, thinking based on our data that this would have a little bit better toxicity profile. And then it's also notable that in this trial, they did allow crossover. So patients who had confirmed progressive disease were allowed to cross over to BTKi therapy. So this was also a positive trial in terms of progression-free survival. The addition of acalabrutinib improved PFS over that of standard BR. The follow-up, this is from the primary analysis. It's important to remember the follow-up is shorter than what was seen in the SHINE data. So just thinking about that when we look at in terms of median progression-free survival, but the median PFS improved from 47 to 66 months, and these PFS benefit was consistent across the different risk patient populations. Now, similar to the SHINE study, despite the benefit in progression-free survival, there was not a benefit in overall survival at the primary analysis, again, which was about a median follow-up of 45 months. I'll admit, not always my favorite to show, but a pre-specified analysis, which is my understanding was required by the FDA, was to look at results censored by COVID deaths, and they did see a trend towards benefit in that scenario. So at this meeting, we'll see longer follow-up of the ECHO results, and this confirms the progression-free survival benefit of this combination in mantle cell lymphoma. This, to me, probably with the longer follow-up, looks a little bit similar to the median PFS differences as seen in the SHINE trial, but median PFS of 48 versus 73 months. So this looks at time to next treatment 2, or essentially patients who received third-line therapy. And as you can see, there was a significant number more patients in the placebo arm who received third-line therapy than those in the patients who received BTKi in the front line. And remember, this included patients who crossed over to BTKi as second-line treatment. And in fact, 70% of patients received BTKi as subsequent therapy in the placebo arm. So at EHA, we also saw results based on MRD. Martin talked some about MRD. So we know in patients who are able to achieve an undetectable MRD status that they have better outcomes in terms of PFS and even OS in trials. So they showed in this trial that the ability to achieve an undetectable MRD was associated with an improvement in progression-free survival, regardless of clinical response. So patients who are MRD negative, regardless of CR or not, still did better than those patients who continued to be MRD positive, with the best PFS being in those patients, of course, who achieved an MRD negative CR. What they also showed is that for those patients who maintained acalabrutinib or BTK in the maintenance setting, that those patients had a higher rate of continued undetectable MRD, or essentially a lower rate of converting to MRD positive. What about the toxicity, which was really the concern in the SHINE trial? So as you can see, there was similar rates of any grade and grade 3 or higher adverse events in both arms. there was a higher rate of, little bit higher rate of serious adverse events in the acalabrutinib arm. And like SHINE, there was a higher rate of discontinuation in the BTK arm due to toxicity in the placebo, but it didn't seem to translate into the same concern of treatment-related adverse events leading to death. No new safety signals with longer follow-up. So we talked some about BTK inhibitor toxicities, and I think that Martin hit on some of these, but really in this patient population, thinking about what do we monitor for toxicity and how are we able to help keep them on the BTK inhibitor therapy. So we know that we do not give these concomitantly with warfarin due to the bleeding risk. For hypertension is seen with these. And I think I'll just back up and say that when we look at the BTKi inhibitors, a lot of these toxicities, they're improved in the second generation BTK inhibitors, but that doesn't mean that they don't happen. So they are classed, there is a class effect and you can see them, but the incidence and severity can be improved. So these are things that we monitor with any of these drugs. Hypertension, this can actually be seen early or can be a later effect. So monitoring for hypertension, thinking about that for patients who have baseline hypertension, it's, and medically managing as we would with patients who are not on BTKi therapy with hypertension. The same can be said for cardiac arrhythmias and atrial fibrillation, monitoring for these if patients are having palpitations or concerns. Do a workup for this. For patients who do develop atrial fibrillation, it's treated similarly to those patients who are not on BTKi therapy with rate control, rhythm control, and then consideration of adding anticoagulation in the form of DOAC with careful monitoring for any bleeding. Monitoring patients for signs of bleeding and secondary malignancies. I think Martin hit on this in his talk, but I'll just highlight it again. So some of the differentiation between acalabrutinib and zanubrutinib, particularly even in the randomized trial, there's been randomized trials in CLL and Waldenstrom's against ibrutinib. But that acalabrutinib, you do see the headache with. In my experience, it usually occurs within the first month of therapy. It usually lasts, maybe a cycle. So it's something you can tell patients it usually is going to resolve in usually, 4 weeks or so. That is very usually well managed with over-the-counter medication, so pain control, and often can be responsive to caffeine. And so if you can get them through that period, usually patients do well without having headache or having to take any of this acetaminophen or caffeine. And then he mentioned that zanubrutinib seems to have a higher rate of hematologic toxicity, and indeed it did have higher rate of neutropenia in some of the trials, which can be managed with dose interruptions, growth factor support, sometimes dose reduction. I will say that, it was easy when patients are given acalabrutinib, it's easier to if they have toxicities to switch to a second generation BTK, and often you'll see that the toxicity doesn't recur, or recurs at a lower grade. But you can do the same with these second generation BTKi as well. Okay, so let's get back to Megan and how do we approach treatment for Megan? So is she a candidate for chemoimmunotherapy alone? Do we give her BR, R-CHOP, BTKi in combination with chemoimmunotherapy? Or would you approach, chemo-free treatment with BTKi doublet or triplet? Christine?
Sure. So I think, this is really a very real life situation and ends up being actually a long discussion with patients, I think. So I think we have very solid data for BR on its own with rituximab maintenance for a patient just like this. The echo data, as you saw, definitely showed a significant improvement in progression-free survival. I personally am really excited about seeing the longer-term follow-up, especially with the overall survival curves. I think one question for this patient population is whether combining the BTKi with the chemo versus taking that sequential approach, which is more efficacious, especially when we think about added toxicity of BTK inhibitor to chemoimmunotherapy. So I think, though, if we really are seeing that overall survival signal emerge, that is really a strong argument for adding that BTKi up front. And then the chemo-free approach, we'll get into the data for that in the next portion of the talk. I think for right now that those data and those studies are still evolving. So I think for a patient that is chemo eligible, I think thinking about a chemo-based approach here is still very reasonable.
No, quite similar. And what are the things which would guide me in this the treatment of this 73-year-old lady is first of all, 73-year-old in our current patient population is rather young. So usually it's we're talking between 75 or 80. Yes, this is probably a patient who could well tolerate the bendamustine. However, what I would consider is when we're talking toxicity, and you're right about this combination. So the major toxicity from my point of view is coming from the bendamustine. So in this lady, I would from the beginning on reduce the bendamustine dose to 70 milligrams and probably cut to 4 cycles of bendamustine only. And then really taking the info we have from Triangle, from other trials, also by the Spanish group, I would consider to stop the BTKi maintenance after 2 years if your patient has a high quality response.
I think that's a good point, right? Can we take both SHINE and ECHO gave BTKi until progression, and we know that there is cumulative toxicity, particularly after chemoimmunotherapy, and can we take that time-limited BTKi approach that Triangle did in these older patients to give them less exposure to the BTKi, and then maybe even retreatment, which is a whole nother question. So, sticking with this same patient, so if we chose to give her just BR or we chose to give her our BTKi, does ECHO support the use of the ABR regimen in this patient? And what should we think about for safe delivery? I guess, Martin, you mentioned kind of dose reduction of the bendamustine, time-limited BTKi.
Yeah, I think those are excellent considerations. I think that point about time-limited BTKi is very important. So I was alluding to this question of concomitant versus sequential, but if you are using a time-limited BTK inhibitor up front, then you still allow the patient potentially to have that long treatment-free interval. And Cami, as you mentioned, I think we need to understand better about the possibility of retreatment.
So let's go back to Megan, similar to what we did in Martin's presentation, and let's consider her case if she has different risk features. So now Megan has high-risk MIPI instead of intermediate-risk MIPI, although we've heard from Martin that's not as important of a factor. But other findings include now her Ki-67 is 50%. So greater than 30% is less favorable, but we know 50% or higher has considerably worse outcomes based on the MD Anderson and some other cohorts. So at EHA, we saw outcomes based on high-risk categories. So I told you earlier in the presentation that the PFS was independent of the PFS benefit with acalabrutinib was independent of of different disease risk features. So this was an analysis in the high-risk subgroup of patients, and the initial analysis did include consideration of patients as high-risk, both by high-risk MIPI and then TP53 mutations, Ki-67 30% or greater, and blastoid or pleomorphic histology. In that high-risk population, they showed an improved complete response rate with the addition of BTKi, but also an improvement in the progression-free survival. However, on the right, you can see, and I think more importantly, is taking out the high-risk MIPI. As we know, a lot of these patients can be that by age determination, and really just looking at outcomes based on those biological risk factors. So what happened in the patients with high-risk disease by Ki-67 greater than 30%, blastoid or pleomorphic disease, and TP53 mutations? And in this high-risk biological group, there was still a benefit to the addition to BTKi to the chemoimmunotherapy with median PFS from 33 to close to 50 months. So when they looked at it by the different factors, this held across Ki-67 and blastoid disease. The TP53 numbers were too small on their own. to make a good conclusion. So also data that will be shown later at ASH is looking at outcomes by POD24. So we know that patients with POD24 have worse survival in mantle cell lymphoma. And so this abstract collectively looked at risk factors for POD24 in the ECHO trial. And as you can see, predictors in the entire patient population of having POD24 are as listed: age, male sex, stage 4 disease, Ki-67 greater than 30%, high LDH, and blastoid disease. But what they showed was that there was a benefit to not having POD24 with the addition of acalabrutinib to the BR. So POD24 rates were 25% in the acalabrutinib arm versus 36% in the placebo arm, translating to a decreased risk in early progression with the addition of BTKi inhibitor. So let's go back to Megan with her high-risk features. Would you still consider a candidate for the acalabrutinib BR regimen? And what is your thought on approaching these patients with high-risk disease?
Well, that's a difficult question, to be honest, because it's true that the benefit of the combination BR plus Acala was more pronounced in this patient population. On the other hand, bendamustine backbone is probably not the best one in a lymphoma with Ki-67 of 50% or higher. So in the European series, this is probably in the range of 10-15% of first-line patients. So it's really rather extreme high Ki-67. So in this patient, I would probably consider, let's say, an adapted triangle regimen, for example, only R-CHOP plus I. Of course, this is not really proven in studies, but as I said, Germany, yes, is a bendamustine country, but in these specific cases with Ki-67 of 50% or higher, I would be a little bit reluctant.
Yeah, I think that's, as you said, a challenging question. We tend to use a lot of bendamustine still, even in these situations. I think that the Acala plus BR regimen would be very reasonable here. I do think sort of, to the perhaps addressing the second point and more is that this is really an area where I think we still need more investigation and still to understand what is the optimal treatment. In that slide, Cami, with the breakdown by the high-risk group, I think what is also striking is that even in the Acala plus BR, the patients who received Acala plus BR with high-risk features, their median PFS is still numerically much lower than the overall patient population. So we, I think, have not yet solved the answer. I think BTK inhibitors are an important step for these higher-risk patients, but I think that it's still a lot more work to be done.
I think that's a great point. So we know that in other trials, including like Simpatico, that BTKi improved, the combinations improved it over BTKi alone. So you make progress. And here we're seeing improved outcomes in high-risk disease over chemo alone. But we're certainly not matching the general population of mantle cell with our current combinations with high-risk disease. And I think, our next presentation is going to be on the different potentials for non-chemo approaches, and really are some of these patients with high-risk disease best served by other combinations of therapy. So looking at take-home messages on targeted therapy in this patient population who are not candidates for autologous stem cell transplant. So the early attempts at integrating BTKi were unsuccessful, in part due to toxicity, but with better tolerated BTKi inhibitors, we have seen benefit. ECHO has been established as effective in the first-line setting with BTKi in combination with BR for patients who are unable to receive transplant. And this is it's now been approved in the frontline in this setting and included in both the U.S. and European guidelines. Applying, when we think about these BTKi inhibitors, thinking about applying safety and monitoring principles, when using these agents as first line in conjunction with chemoimmunotherapy. Things like dose reductions or minimizing exposure to treatment may be important in the future. And with that, I am pretty much right on the needle for time, so I'll transition to Christine to talk about the future and chemo-free regimens.
All right. Thank you, Cami, and good morning to everyone. It's really my privilege and pleasure to be here this morning to talk with you about the chemo-free option. So as we look to the future, which is actually now, I think, becoming more the present, but really an exciting area in evolving management of frontline mantle cell lymphoma opportunities with doublets and triplets. All right. So as with our other sections, we'll start with a patient case. And so here we now have Malcolm. And Malcolm is a 78-year-old gentleman with newly diagnosed stage 4 mantle cell lymphoma. You'll see his ECOG performance status is now 2, and he does have a high MIPI score. Focusing in on those biological features of his disease, however, we see that Ki-67 is 25%, so below that 30% cutoff. He does not have blastoid morphology, and he has TP53 wild-type disease. Now, notably for this patient, as we think about our older patients with mantle cell lymphoma, he does have a number of comorbidities, including type 2 diabetes, a mildly reduced ejection fraction of 45%, and chronic kidney disease. So we'll jump right into the data, and what we'll do is first we'll look at some of the key studies investigating doublets, and then we'll look at the studies investigating triplets. And so first starting with the doublet approach, a very important phase 3 trial that was reported at ASH last year and now recently published in full is the ENRICH study. This was a phase 3 trial of ibrutinib plus rituximab versus standard of care rituximab chemoimmunotherapy in older patients. You can see in the eligibility, the age requirement was at least age 60 years, stage 2 to 4 disease, and patients were randomized either to standard chemoimmunotherapy or to the combination of ibrutinib plus rituximab. Now, the chemoimmunotherapy that was used as standard of care, the treating physician actually specified upfront whether the patient receive R-CHOP or BR, so that was a built-in stratified randomization as part of this trial. All patients received maintenance in this study, so in the control arm, patients received rituximab maintenance for 2 years, and in the investigational arm, patients received ibrutinib plus rituximab. The rituximab also given for 2 years, and then ibrutinib continued until disease progression or unacceptable toxicity. Now, this was a positive trial. It met its primary endpoint, and it demonstrated that the approach of BTK inhibitor, ibrutinib plus rituximab, achieved a statistically significant improved progression-free survival compared to chemoimmunotherapy. You can see with the median follow-up of about 4 years, median PFS difference, the ibrutinib plus rituximab arm, median PFS 65 months versus 42 months in the standard of care arm, basically a 2-year progression-free survival improvement. And as Martin showed at the very beginning of this session, we see now that ibrutinib plus rituximab is included in the European guidelines. However, when we look at the analysis by chemoimmunotherapy choice, we do see a significant difference between the two groups. So again, treating physician chose upfront whether patients would receive R-CHOP if randomized to the standard of care arm versus bendamustine rituximab. And what you can see in these two PFS curves are that there is a significant difference in how the standard of care arm performed. So when compared to R-CHOP, we see definitely a very wide margin there of the ibrutinib plus rituximab, improving 5-year progression-free survival, 52% compared to only 19%. And interestingly, when we look, though, at the comparison with bendamustine rituximab, we see that the outcomes were much more similar. So overlapping PFS curves there with a hazard ratio of nearly 1 and very similar 5-year progression-free survival of 50% in the ibrutinib plus rituximab arm versus 48% in the bendamustine plus rituximab arm. So, again, I think implementation of the results of these trials may vary depending on which country that you are practicing in. Again, in the ibrutinib plus rituximab, but because of the results of this trial are now included in the European guidelines, as you've heard with the withdrawal of ibrutinib from indication in the U.S., I think a little bit more challenging in terms of whether this truly supplants bendamustine rituximab for all patients. but to me, very importantly, demonstrates that it can at least be equivalent and therefore brings it to the table as an important option for certain patients who may not be benda eligible. So we do have data for our second-generation BTK inhibitor acalabrutinib as well. There have been actually a couple of phase 2 studies looking at this, one out of MD Anderson, and the one that we're showing here is presented at ASH last year, the Altamira study from the Nordic group. And so in this study, patients over the age of 60 were enrolled and received the combination of acalabrutinib plus rituximab. This study also incorporated actually MRD-guided treatment duration for lower risk disease. So this pertains to the point that we were discussing earlier about time-limited BTK inhibitor upfront, even for these older patients. You can see the very promising progression-free survival curve at 2 years, a PFS of 75% for these patients. And importantly, in this study, the authors also show data where they compared their trial population, the Altamira data set, to historical control. You can see over 200 patients in this MCL complete cohort that they compiled and showed that this BTKi acalabrutinib plus Ritux approach does appear to have a superior PFS compared to that historical control. Now, there is an ongoing phase 3 trial of zanubrutinib with rituximab in the frontline as well. So we will see another study very similar to the enriched study comparing a second-generation now BTK inhibitor with rituximab to standard of care bendamustine rituximab. So all patients in this study received BR as their standard of care arm, and we anticipate the results of this trial hopefully in the near future. I think definitely has the opportunity to be a high-impact trial and potentially change our standard of care. There is also an ongoing trial in the UK, similarly investigating the combination of acalabrutinib plus rituximab. And so, again, more studies contributing to this growing body of data of the doublet BTKi plus rituximab approach in older patients. All right, so now let's turn our attention to the triplet combinations. And the OASIS study, so there's OASIS 1 and OASIS 2, and so what we're showing here is the OASIS 2 study. And this study was actually a randomized study of brutinib plus CD20 versus the triplet, so adding in venetoclax. This data was presented at ASH last year, and you can see that with the addition now of the BCL2 inhibitor venetoclax, we see an improved response rates, and additionally, we saw increased MRD negativity. Now, of course, when we add in a third drug to a regimen, we anticipate that there will be more toxicity from that. What you can see, though, is that in particular, the neutropenia, but overall, these adverse events were, I would say, well manageable. And so we do await longer-term follow-up of this study. We also have triplet data incorporating second-generation BTK inhibitors. So I'll show you some results with incorporation of both acalabrutinib and zanubrutinib next. The AVR combination, so acalabrutinib, venetoclax, and rituximab, has shown very promising results. You can see overall response rates of 100% and very promising progression-free survival curves. You can see the 2-year PFS when, again, as Kimi mentioned, a little bit challenging sometimes when we censor with COVID, but this particular study was run right in the height of the COVID-19 pandemic. You can see when the deaths are censored by COVID-19, a 2-year PFS of 95%, which is really quite remarkable for this triplet. In addition, high rates of MRD negativity. And as we have been discussing with the second-generation BTK inhibitor, we do see less of those toxicities that we know are common with the first-generation BTK inhibitor, ibrutinib. Now, at ASH this year, we will also see results presented of this same triplet, acalabrutinib, venetoclax, and rituximab in the TRAVERSE study. This is an over 100-patient study where patients received this triplet of acala-ven and rituximab. You can see very high, again, overall response rates of 95%, and we are also seeing high MRD negativity rates. Earlier follow-up data included in the abstract. We anticipate probably longer follow-up will be presented, but that is a session to have an eye on Monday. Now, the triplet of zanubrutinib, venetoclax, and obinutuzumab has also been studied in frontline mantle cell lymphoma. When we focus in on the high-risk data, we'll look at this a bit more, but the bovine regimen has become increasingly familiar, I think, because of the initial investigation in the high-risk group. The group at Memorial Sloan Kettering also had a concomitant study investigating this triplet in older patients or transplant-ineligible patients. And so we'll see at this conference, again on Monday, a cohort of 50 patients who received this triplet. And we, similar to what you've been seeing, are seeing very encouraging results. Best overall response rate, again, of nearly 100%, very high CR rate of 94%, and very encouraging 2-year progression-free survival of 86%. So another abstract that'll be presented at this conference that we wanted to highlight. All right, so as we come back to Malcolm, again, our 78-year-old gentleman, older and with some comorbidities, I'll turn to my esteemed colleagues and ask, what is the rationale for potentially considering a chemo-sparing regimen with a BTK inhibitor in this patient? Or is this a patient you would consider BTK inhibitor plus a lower intensity chemoimmunotherapy regimen? Martin, you had mentioned already about lowering bendamustine. Or is this a patient you might consider just still standard of care, potentially BR on its own? So maybe, Martin, I'll start with you.
Well, of course, we are all situated in our national health system. So in Germany specifically, we could not go for a non-chemo approach right away. However, we all know the games. So me personally, I would really try to avoid chemotherapy in this chap because he is a low-risk patient. So he has pretty good chances. We didn't show the data. Also in the enriched trial, the low risk or standard risk patients were the ones who benefited most. And therefore, I would probably just start with 1 dose of bendamustine to fulfill the registration and then afterwards skip that all over.
Yeah, so I think this is the question in some of these patients, and it always kind of depends on the comorbidities, but is really, are you thinking about kind of a dose-reduced BR versus R BTKi, right? And I think there are some patients with low-risk disease that get very long and good remissions with chemotherapy, but then if you're trying to give them rituximab maintenance after BR, this is a patient that's going to have a lot of infectious complications, and it's going to be very hard. Whereas I feel like with the newer generation BTKIs, giving an RBTKi in this patient population that doesn't have high-risk disease, it produces very high response rates and very durable remissions, and in general is going to be probably fairly well tolerated. So my preference really in this kind of patient is to try to lean towards, rituximab, a doublet therapy with a newer generation BTKi.
Yeah. Now the question to you, Christy. So
Yep.
I'm sorry for pushing for that, but now let's we somewhat agree that we would spare major doses of chemotherapy. So let's say this patient is responding well. Now in US you have the opportunity to perform MRD. So let's say after 2 years you perform MRD and this patient is MRD negative. Would you stop BTKi?
Yeah, I think that the question of how to incorporate MRD into our practice is really evolving. I think for us right now, it's information that I'm gathering, but I don't know that we really have the evidence that tells us the best way to make decisions with that MRD. And as you pointed out, Martin, there are studies that show those patients who are MRD negative are actually the ones who benefit most from the ongoing maintenance. So I think that outside the context of a clinical trial, I'm not discontinuing treatment based on MRD alone. All right, let's now, maybe for the sake of time, we will, I think, maybe move through these discussion questions or come back to them at the end. I think, Cami, you talked a little bit already about how to manage toxicities of BTK inhibitors very nicely. So now let's change a couple of important features of this patient's disease. And so now the biological features, we will see an elevated Ki-67. Now we are making this a blastoid morphology and TP53 mutated. So taken all together, I think that clinically we all, if this patient were to walk through the door, think about them very differently than we would with the first Malcolm, we'll say. All right, so moving into our triplet data. The MAVO study is a study that we are leading at Dana-Farber. My colleague, Austin Kim is the principal investigator, and updated results from this study will be presented at ASH on Sunday. This is the triplet combination of acalabrutinib, venetoclax, and obinutuzumab in high-risk, both relapse refractory as well as treatment-naive mantle cell lymphoma. This study incorporates acalabrutinib, a lead-in, to minimize the risk of potential infusion reactions with obinutuzumab, which is introduced in cycle 2, and then venetoclax introduced in cycle 3 after 2 cycles to hopefully minimize the risk of TLS. So a stepwise introduction of these 3 agents, just a slight difference as we'll see from the bovin regimen. And what we know about this triplet is that it can achieve very high overall response rates, focusing in on initially, we have a treatment-naive cohort of p53 aberrant or transplant-ineligible patients, as well as we had a lower-risk cohort of p53 wild-type disease. But focusing in on those patients who are p53 aberrant or transplant-ineligible, overall response rate of 88% with a high CR rate of 80%, both in the entire cohort as well as those specifically with p53 mutation. This was, as Martin, you were asking, about MRD-guided treatment. So in this study, again, in the context of the clinical trial, we did employ MRD-guided treatment discontinuation. So patients would discontinue the acalabrutinib and venetoclax after 7 cycles, actually, and then continue on with obinutuzumab maintenance for up to 2 years. And the 2-year PFS that we're seeing so far, favorable at 78%. Now, as I've been alluding to, the bovin regimen, which was presented at ASH 2 years ago and published in full and made it into the NCCN guidelines, also, we will see updated results for at ASH this year. I think Cami alluded to this, but with the inclusion of this in the NCCN guidelines, this is a triplet that is increasingly being used, particularly in the U.S., for patients with high-risk p53 mutated mantle cell lymphoma. At ASH this year, we'll see with a median follow-up now of just over 3 years, a median progression-free survival of just under 4 years, and a 3-year PFS of 64%. This trial also employed MRD-guided treatment duration, and so patients would discontinue treatment when MRD undetectable, and you can see that a very high percentage achieved that MRD undetectable at 10 to the minus 6, and actually all of them were undetectable at sensitivity of 10 to the minus 4. All right, so I wanted to make sure that we had enough time at the end for all of your questions as well. But to just briefly recap the experience with second-generation BTKi triplets in mantle cell lymphoma, what we see is that we have the predictable BTKi class toxicities, predominantly lower grade though, usually 1 to 2 in nature, overall lower rates of atrial fibrillation with the second-generation BTK inhibitors, and we do see very good tolerability even in older or high-risk patients. The cytopenias are a consideration, particularly with the triplet regimens, what we're seeing emerge, and likely reflects the additive myelosuppression from the venetoclax in combination with the CD20 antibody. So it is important in these patients for for close monitoring and vigilance for infections. But infections we have seen are manageable with prophylaxis and monitoring. All right, so now I'll turn the discussion back to my colleagues and say, if Malcolm had presented with high-risk disease, is this a patient that you would consider a chemo-free triplet, or is there a role for chemotherapy still for him? Maybe, Cami, we'll start with you this time.
Yeah, so I think, as you had mentioned, I have been incorporating the bovin regimen into my patients with high-risk disease, specifically those patients with TP53 mutated, because that was a population of patients that was studied, and then the NCCN guidelines, although the population was small, that has been kind of my regimen of choice in both older and honestly younger patients with TP53 mutated disease. But I've also, which this Malcolm currently has, I have also considered it in patients, with higher risk Ki-67 as well.
Pretty much agree in that way. Now we're talking about a 78-year-old chap, and in real life, there are some comorbidities. So I think it will be difficult in such a patient to apply, a CHOP-like whatever regimen plus targeted therapy. And really, we have to go for BTKi because of p53 mutation. No discussion about that. And my bias is that for classical or low-risk patients, I go for BTKi mono plus minus rituximab, and for the high risk, I really go for the triple combinations. There was in the chat an interesting question whether we then really need rituximab or whether we are well off only with BTKi plus venetoclax or others. And if you do a study-to-study comparison, having a look at the sympathico data, at the triple combination data, it seems to be that also for these combinations, rituximab does add. So I would be in favor.
Yeah, I would agree with that. I do think that we've had a lot of very robust data confirming that the CD20, I think, is a very important part of treating this disease. And I agree, just to comment on the adding in the BCL2 inhibitor as well. We know that there is likely synergy between BTKi and BCL2i. And so I think that especially when we're thinking of patients with more aggressive biology, aiming for the triplet whenever possible. All right. And then we wanted to just also have an eye to the future. You know, Cami had mentioned when we were talking about our wish list for Christmas, what we want in this disease. And I think that it is really exciting to think about what is on the horizon in terms of what more can we incorporate into frontline management of this disease, and thinking about the T-cell engaging therapies, whether that's CAR T-cell therapy or the bispecific antibodies. And so this is a study that will be presented at ASH this year as well. This is out of MD Anderson, one of the window studies. And so in this study, patients start with acalabrutinib plus rituximab. And then for those patients who only have a partial remission or stable disease, actually move on to early CAR T-cell therapy with Brexucel. And so think, what we saw in the abstract, at least still early follow-up, but a very interesting concept in terms of bringing CAR T-cell therapy into earlier lines of treatment. All right, so our take-homes on the chemo-free future. The BTKi plus rituximab doublets, let's start with that. So as we saw, the enriched study of ibrutinib and rituximab versus chemoimmunotherapy did meet its primary endpoint. Very importantly, now included in guidelines, in the European guidelines. The PFS benefit, as you saw, though, is mainly driven by the comparison to the R-CHOP arm as opposed to the bendamustine rituximab arm, but nonetheless provides a very important comparator between chemo-free versus BR. And from additional data we have with the second-generation BTK inhibitor, we know that acalabrutinib plus rituximab demonstrates very promising efficacy in the frontline setting. Looking ahead, we have the Mangrove study that we anticipate readout from, which will assess the combination of zanubrutinib and rituximab compared to BR. And when we think about triplets, as you've heard from the panel, really we favor this whenever possible for those patients, particularly with p53 aberrant disease, as that is what the Bovin study and our MAVO study were focusing on. We do look to the horizon for data with these triplets with other high-risk features. And I think as we think about incorporating this into our frontline management, that longer follow-up, larger studies, and of course, ideally our gold standard randomized studies will be needed to really cement the place of triplets as a new standard of care for mantle cell lymphoma. I think at this point, we'll open it up for Q&A.
Table, we have a couple of questions also from the chat, and I would like to go through that. First point, you mentioned that already, Christine. So maybe I really ask Cami. So what about the early use of CAR T cells after patients progressing after BTKi containing first-line treatment?
So I think that there is for CAR T cell therapy in patients who progress after primary BTKi therapy. So as we inhibitors into the frontline setting, that's going to leave us with, since that was our standard and essentially all patients, at first relapse, it's going to lead us with a need to improve therapy in the second line and later setting. And I think that this is where CAR T cell therapies in the U.S., we now have 2 CAR T cell therapies approved. In my view, one has a lot more toxicity, but one has a lot less toxicity and is better tolerable, and it can be given in older patients. So I think that that's primarily if my patient is a candidate for one of those therapies and has progressed in the setting of BTKi in the front line, that is where I'm using it. I think the question remains that the patient progressing on it or shortly after, if a patient has first-line BTK inhibitor therapy and gets a, 7-year remission, can you reuse a BTKi in some sort of combination? And then I think if you look into the future, the bispecific antibodies are probably going to play a role here as well.
Christine, I have a hot potato for you, which is what is standard of care in patients with p53 mutated mantle cell lymphoma? So I can answer the easy part of the question. Well, definitely a BTKi containing regimen is better than chemotherapy only. However, we probably have different approaches in these patients, whether to add chemo to BTKi or not. Are there any patients where you could envision adding chemotherapy to BTKi in these patients?
Yeah, I think that this actually remains one of our unanswered questions in the field. And as I was alluding to, I think we really do need comparative studies in this patient population. As Cami and I have been saying, in the U.S., I have reached for Bovin, so a chemo-free approach for patients once the data was published and with the NCCN guidelines. But there are some patients who, even still progress either rapidly through that or, have not a very durable response. And so those are patients where, exactly as Cami is saying, we're then thinking about early CAR T-cell therapy. But there are some patients, I think, with just very highly proliferative aggressive disease biology where I do wonder whether that BTKi plus chemotherapy really might be a more effective, at least initial approach before moving into the chemo-free approaches. So, I think this is a patient population where we really try to enroll them in clinical trials because I think that trying to understand better and generate that data is very important. But in a patient who is eligible for chemo, Martin, to your question, I do think that there could be a role for thinking about that, for example, ACALA plus BR combination in them as well. One consideration I'll say is that, if it's a patient that you are thinking may need CAR T-cell therapy early on in their treatment course, that's one hesitation, for example, to use bendamustine because we worry about the effect on T-cell fitness, et cetera. So it's tricky.
And that tells you, sometimes it's difficult to transfer these data to real life. I fully agree in the high-risk patients where you have the largest benefit of, according to ECHO, by BR plus chemo, plus BTKi. Then if you expect early relapse, you have a trouble with bendamustine. Fully agree. Now, this is the more visionary question to you. Let's say if we sit together in 5 years from now, what will be the standards of care? And you pick your favorite patient subset, and then we go all through the podium, and everyone can pick his favorite patient.
So, in my opinion, probably with the bispecific antibodies, we're going to be using combination with bispecific antibody and oral targeted therapy in doublet and triplet in the frontline setting in high and low risk disease.
Cami and I think very similar. I also agree that I think it would be very exciting to see bispecific antibodies in the front line. I think envisioning some type of tailored treatment approach, though, whether that's with MRD, to really understand what is the best duration of treatment up front. I think there are patients who benefit from ongoing prolonged maintenance. There may be patients who do not need that, and therefore we can allow them the treatment-free intervals. But I do think incorporating both these immune therapy, the bispecific antibodies, plus our oral targeted agents, and as Cami mentioned at the beginning, maybe not needing chemotherapy at all would really be wonderful.
Well taken. I think we all agree in the standard risk patients, we may be well off with BTKi plus R only, maybe in the intermediate risk, adding venetoclax or second generation substances. The big question, though, will probably be what is the role of immunotherapy, may it be registered CAR T-cells or bispecifics, which are not yet registered, but which are intensively investigated in clinical trials. So I think also in 5 years from now, there will be plenty of things to be discussed for mantle cell lymphoma. I really would like to thank you for your excellent presentations and discussions. I want to thank you for all of your input, also the questions you brought up. And then finally, I would also thank the support of HealthTree and the organizers. Wish you a successful ASH 2025.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is developed with our educational partner, the HealthTree Foundation for Mantle Cell Lymphoma. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/GKD860.